Good morning, everybody, and welcome to Internal Medicine Grand Rounds. I am not Simmerjot Jassel. I'm Taylor Doherty from Allergy and Immunology. And today I'm really pleased to have our annual Stephen I. Wasserman Immunology Lectureship. Dr. Stephen Wasserman is a world-renowned physician, researcher, teacher, and mentor who's been a member of the Division of Rheumatology, Allergy, and Immunology at UCSD for over 40 years. He founded the Division of Allergy and Immunology after moving from Harvard to UC San Diego in 1979. Dr. Wasserman was chairman of the Department of Medicine from 1986 to 2000 and held the Helen M. Rainey Chair from 1988 to 2001. Dr. Wasserman also served as the president of the American Academy of Allergy, Asthma, and Immunology, as well as the president of the American Board of Allergy and Immunology. After stepping down from his position as chairman, Dr. Wasserman continued making important contributions in clinical care, research, teaching, and service until his retirement. Dr. Wasserman had an enormous positive impact and continues to on the careers of countless trainees and colleagues. The annual Stephen I. Wasserman Immunology Lectureship at UC San Diego was established by his mentees in grateful recognition of his contributions. The purpose of this lectureship is to bring internationally recognized investigators to UC San Diego for seminars and teaching activities. The year of 2019 was the inaugural Stephen I. Wasserman Immunology Lecture. The program continues to enhance training for our fellows, serving as new educational venue that brings top scientists to San Diego and continues the tradition of excellence that exemplified Dr. Wasserman's career. And now it's my pleasure to introduce our speaker for the third annual lectureship today. And that is Dr. Mariana Castells, who is a professor of medicine at Brigham and Women's Hospital of Harvard Medical School. She is the director of the Drug Hypersensitivity and Drug Desensitization and Mastocytosis Centers and served as the Allergy and Clinical Immunology Training Program Director at Brigham for 10 years. Dr. Castells has spearheaded the evaluation and understanding of anaphylaxis and drug hypersensitivity and has developed desensitization protocols which are used as standards around the world, a true pioneer. These advances have allowed thousands of patients with cancer and chronic inflammatory diseases to remain on their first-line therapy. Her research has uncovered mast cell inhibitory mechanisms which are pertinent to desensitization, and her laboratory is actively pursuing pharmacologic candidates to improve diagnosis and treatment of mast cell activation disorders and mastocytosis. She is currently the PI of clinical trials with novel tyrosine kinase inhibitors. Dr. Castells has also served on the board of directors of the American Academy of Allergy, Asthma, and Immunology, also known as Quadruple AI, and is now the research chair of the Quad AI Foundation. She is on the board of directors of the American Board of Allergy and Immunology and has been at the editorial board of several impactful journals, including Journal of Allergy and Clinical Immunology. Dr. Castells has also received numerous honors and awards, including the Quad AI Distinguished Clinician and Academic Excellence Award. It is my pleasure to welcome Dr. Castells to give her talk entitled Hypersensitivity, Drug Desensitization, Mastocytosis for the third annual Stephen I. Wasserman Lectureship. Dr. Castells? There we go.
Can you hear me?
Yes.
Perfect. Thank you so much for this very nice introduction. I will make a quick correction to that. I've served as the training program director for 25 years, not 10 years. It's been a long time, and I love that position, but the new generations have to take over. I am delighted to be here and to speak in this lecture that bears the name of a very esteemed mentor, a colleague, and a friend. And what I wanted to do before I start to talk about, the drug hypersensitivity is to bring a little bit, I wish I could be there and I will bring a little bit of the extended Harvard family that Dr. Wasserman has to you. Let me just see. Is my screen being shared?
It is not yet.
Okay, let me just see if we can share that. Okay. All right. Can you see the screen?
It. Perfect.
Perfect. Very good. Let me just see if we can move this a little bit. So I'm not sure why it's not moving right now. It was, oh, here it is. Maybe it's okay. Maybe it's moving now. So as I said, I wanted to bring a little bit of the extended family of Dr. Wasserman to you today. Dr. Wasserman has actually helped tremendously my career and supported me all along the way. And he has been a tremendous mentor and in terms of, you know, female clinicians and female scientists and researchers advancement. He trained, as I said, at Harvard and he's one of the giants of allergy and clinical immunology in the world. He trained with the father of modern allergy, Frank Austin, who is here in this picture. You can see Frank. And very early, he told us, Steve and all the other people who have been mentoring through Frank Austin, a mechanistic venue for our discipline. So he is the first one putting together mechanisms of allergy, and that's what we have continued to do. And here you can see Dr. Wasserman with all the other giants from the NIH, Dean Metcalf and Steve Holgate and Larry Schwartz and myself at the 90th birthday of Frank Austin. I also want to bring, you know, a really great friend of and a mentor to me, Albert Sheffer, and his wife, Barbie Sheffer, who Dr. Wasserman has been a long time associated with, and I'm sure he will be happy to see this picture. One of my favorite cells in the immune system is the mast cell, and we share the same passion with Dr. Wasserman. This is one of my favorite publications where what he did is he reconstituted the mast cell population in a mouse that was deficient of mast cells. And what is of great interest is that he indicated that not all the tissues can be reconstituted with mast cells, so that the milieu, the environment, is really critical to the development of the mast cells. And I have at the same time been working myself on the same theme with Larry Schwartz and during my PhD, where we describe what is called the human mast cell phenotypes. And that indicates that mast cells are not made equal, that mast cells in the skin are what we call mast cell TCs. They have huge granules. A lot of mediators in mast cells in the mucosal membranes do have only tryptase and fewer granules. And there is a mast cell kinase only positive in the intestine, which, you know, with further investigation has led to the seminal paper here in 2016, a couple of years before Frank Austin's 90th birthday, when we met in the earlier pictures, indicating that mast cells are powerful cells of the innate immune system at the conjunction with immunity and active acquire immunity and innate immunity. And here you have the transcriptome of mast cells, and you see that every mast cell that develops in a different tissue has a different phenotype and a different array of expression of genes and proteins. And you see that mast cells are really separated from all the other immune cells. So this actually has been one of my passions, and that developed into what I'm going to talk to you today about drug hypersensitivity in the 21st century. And two essential aspects of that would be how do we delabel patients, how we do desensitize patients. To do that, I am going to tell you a little bit about first what happened with COVID vaccines. We cannot talk about any drug hypersensitivity without talking about what really happened to that. And this is the article that we wrote, Elizabeth Phillips and myself, for the New England, when Chef Drazen told us the vaccines are out, the first anaphylactic reactions occur within weeks of having the vaccines. And that occurred with the Pfizer vaccine. And 2 females that were healthcare workers that had food allergies and developed anaphylactic reactions. And what happened since then to now is that we have now understood more what is really the hypersensitivity of the COVID vaccines. We understand that most, if not all, the cases of hypersensitivity to the mRNA vaccines are in females, that the mechanism of those reactions is an activation of mast cells. In the cases, as you see here, in which tryptase has been drawn, tryptase has been elevated, but the mechanism may not be all IgE. You have here that basophil activation test has been done, and this is work from my colleagues at Stanford with Karen Nadeau and all the other colleagues, Steve Galley, indicating that the basophils from patients who react to the vaccines can be activated and express CD63 the same way they do when we use anti-IgE, but that is likely not totally Ig mediated. So there is potential for mechanisms that are not driven that may be direct activation of mast cells. What we know now about vaccine hypersensitivity is that anaphylaxis is rare, but 10 times higher than to other vaccines. It's 1 in 200,000, 1 in 250,000. There's no fatalities. But of great interest, only females are affected. 90% of the cases are in females, and epinephrine has been able to solve all the cases. Tryptase has been elevated and should be obtained. And skin tests to the components of the vaccine has not been clearly yet determined. People who have reacted to other medications who have polyethylene glycol or polysorbate or other vaccines have actually been able to receive the vaccine with no problems. And I'll show you an example. The basophil activation test might actually be a good test to identify those patients. And there is no contraindication for the vaccines in people who have previous allergies, even anaphylaxis or mast cell activation disorders. We have used some pre-medications, and the people who have had large reactions, those have a tendency not to recur. The mRNA vaccines are well tolerated by patients with mastocytosis. Is of interest is that when we looked at the AC2 receptor in mast cells, we saw that the AC2 receptor is actually absent in bone marrow mast cells, and we believe that in the rest of the other tissue mast cells is also absent, so that patients with asthma, patients with anaphylaxis, with allergies, and so on forth, when they have COVID infection, they don't have more severe and active mast cell activation symptoms due to the lack of penetration of the COVID virus into mast cells. We have been able to actually provide the vaccination for the doctor, a Boston doctor who was reported in the New York Times when he had the second mRNA vaccine, Moderna, and this happened very quickly after. Also, this was dated December 25th, Christmas Day 2020. He was on call, he received the vaccine and then had to be hospitalized just for a few hours with 2 epinephrines. He had a very high background for food allergies, and he came back to us. We monitor their levels. The levels were declining because the other vaccine was also containing polyethylene glycol. We resorted to give pre-medication, and you have here the recipe, and we actually did a what we call mini desensitization, and he tolerated the vaccine very well. So what I want to do today is to kind of familiarize you what is drug allergy in precision medicine and 21st century, and what are the mandates for internists, for ER doctors, for anybody who is going to be finding that their patient says, I'm allergic to, I had reaction to, what can I take, what can we do? The mandates that we have now is to do the 5 things that we have here listed with the help of, MR medical records, with potential genotyping, with epidemiological data. Because at the end of the day, what we want is to make an accurate diagnosis, to have a targeted treatment option or recommendation, and then to have a better outcome. So phenotyping, what do we see? Endotyping, what's happening underneath? What can we understand better what's happening by evaluating biomarkers? Delabel, which I will spend some time, or desensitize. So this is kind of what I would like you to take the whole message. What we call phenotyping is dependent on the medication. So we have that allergy phenotypes are going to depend on how quickly the reaction develops, what type of medication, what are the symptoms, and what is their severity. The endotype is, can we actually make an assessment of either a type 1 Ig mediated or non-Ig mediated reaction? Is it a delayed reaction? What is also the severity? And the new kid on the blog we have now, cytokine release reactions, which I'll spend a few minutes, and our biomarkers. We have to, and we will talk more about the biomarkers. So if we talked about penicillin, which is the kind of the most common drug allergy that we have, we can say that each drug has a unique pattern of reactivity, which depends really on the chemical structure, but also on the interactions with the immune system and the host characteristics. You have here that penicillin has what we call the beta-lactam ring, but the beta-lactam ring is also surrounded by what we call the R chains, and those R chains are going to be shared or not shared with other beta-lactams from amoxicillin to all the cephalosporins. So potential cross-reactivity between all beta-lactams exist in the setting of a patient being sensitized or sensitive to beta-lactams. When we talk about endotypes, we talk about Gell-Coombs, and you're all familiar with that. But let me just be clear that every drug has potentially side effects. So even an antibiotic can induce diarrhea, can induce nausea, can induce some symptoms that are actually directly related to the action in terms of what the antibiotic is supposed to do. Now, what we call antibody-mediated reactions are reactions that depend on the immune system. So we have here what we call, and I'll show you examples of type 1 reactions where a patient receives an antibiotic, a chemotherapy, a monoclonal several times, develop IgE through the interaction between T cells and B cells in the presence of IL-4, IL-13. IgE is now bound to the IgE receptor on mast cells, potentially on basophils. And then when re-exposure occurs, there is the release of mediators. We also have that type 2 reactions where IgG antibodies are actually also pre-made, and in the presence of the drug, then there is lysis and destruction of red blood cells in hemolytic anemia. We do have that those IgG antibodies can actually produce immunocomplexes in what we call serum sickness, and those can deposit in the skin with rashes, in the kidney, in the liver, and the lymph nodes. We also then have what we call cellular mediated immunity, which is that T cells can be activated and can be sensitized and can actually release mediators that can give rise to what we call maculopapular benign or exanthematous rashes, or much more severe, what we call SCAR, severe cutaneous reactions associated with systemic symptoms, which include the Stevens-Johnson, the DRESS, and the AGIP. When we talked about IgE-mediated reaction, type 1 mediated reactions, we have to think about the possibility of inducing those reactions through mast cell activation. But we know now, which we didn't know before, that mast cells can be activated by many receptors, not only the IgE receptor, IgG receptor here, and KIT, one of the tyrosine kinases that is in the surface of the mast cell and induces mast cell maturation, mast cell activation, and the new kid on the block, MRGPRX2. So what is MRGPRX2 is a G-coupled protein receptor 7 span through its transmembrane, and mediates reactions to general anesthetics and to antibiotics such as quinolones, like patients reacting to that. We have learned now also that vancomycin, for example, can induce reactions through this same receptor, and those reactions can be dose dependent, rate dependent, and can be as severe as inducing anaphylactic reactions, and those will not be IG mediated, so that doing a skin test evaluation will not help. The release of those mediators is powerful. We have preformed mediators such as histamine, but tryptase is released, and tryptase is your friend who will indicate how severe those reactions are. There is also lipid mediators, prostaglandins, leukotrienes, and patients can present from hives to hypotension and cardiovascular collapse. On contrast, in the other side, we have what we call type 4 reactions, and I'll go to the more severe and more dramatic presentations. We have Stevens-Johnson that can be induced by a monoclonal antibody. This patient has been treated very successfully for adult T-cell leukemia. She presents with this phenotype. And this phenotype did give rise to Stevens-Johnson, but also some desquamation, potentially toxic epidermal necrolysis. The endotype is this infiltration of lymphocytes, and the biomarkers are the fact that those lymphocyte infiltration CD4, CD8 markers were found. The same thing happened here with a patient who had a known type 4 penicillin hypersensitivity. Maculopapular rash, maybe the story was not completely right. We didn't spend enough time. The patient had some mouth ulcerations. The patient is given meropenem and presents this severe rash that we see here with oral mucosa and genital involvement. That is not only severe enough that can send the patient to the ICU, but that can have very prolonged and long-lasting side effects that decrease dramatically the quality of life of the patient. So are we beyond gel and Coombs? We are. We have now found that patients react in different ways also, not only as we are saying type 1 IG and non-IG with flushing, pruritus, hives, chest tightness, shortness of breath. We also have that patients can have fever, chills, rigors, nausea, vomiting, hypotension, and that is completely different. That we have seen clearly with chemotherapy drugs such as oxaliplatin. We have seen with many monoclonal antibodies such as rituximab. We have not seen that with antibiotics yet. And we have seen also mixed reactions where patients can present features of type 1 reaction with this cytokine release syndrome. And we also have seen that patients can react to complement receptors. And in those patients, some other mediators such as histamine can be released. So again, we are now expanding our understanding of those phenotypes that we see, and we are clearly doing we are actually helping through the biomarkers understand the mechanism of those reactions and then providing help for the management and potentially reintroduction of those medications. And we see here that we treat those reactions with epinephrine, and we actually make an assessment, can we actually desensitize those patients? So we see here in this review that we published with Dr. Khan and Dr. Phillips a couple of years ago, that in the green are the low to medium risk penicillin allergies. So patients who have presented, and we'll review in a second, some nausea, diarrhea, symptoms that are not suggestive of hypersensitivity type 1 or any of that, we can actually introduce the notion that it could be challenged and not even going to skin testing. For the intermediate patients who have more of a type 1 hives, different type of flushing or itchy rashes, shortness of breath, we can actually do skin testing and decide if the patient has a negative skin test to challenge that patient. And in high-risk patients, we can actually discontinue and make sure that the patient has a label of not being ever reintroduced to any of those medications when there is a pattern or a phenotype of Stevens-Johnson, DRESS, or AGAP. And in patients who have had anaphylactic reactions in the middle, we have desensitization. Why is delabeling so important? It is because 20% of the population that engage in medical care is going to tell us that they have a penicillin allergy. And this will make the patient have complicated personal implications. They will have fewer antibiotic choices. They have more side effects, and they have to use more broad spectrum antibiotics and potentially have more infections after surgical procedures. There's a public health implication that we are going to create antibiotic resistance and going to have more C. diff infections and more costly antibiotics. So not to mention the costs and the expenses, which is not a minute part of the problem, and increased length of hospitalization. And when we do a formal delabeling and evaluation, we can see that about 1% of those patients might continue to be allergic to penicillin. So the impact of having a patient come to us and say, I'm allergic to penicillin is tremendous. I used to do rounds with Dr. Scheffer, as I showed you his picture, and his thought and his teaching when I was a fellow, first-year fellow, was if somebody comes and says penicillin allergy, the first thing to do is never take penicillin again, and potentially never take any beta-lactam again. 20 years plus here, the answer is completely different, is tell me what happened, I will do a risk stratification, and potentially you can go back to penicillin. Because the implication of having a patient in front of you who said, I have a penicillin allergy, are, as I mentioned, not only the broad use of broad spectrum antibiotics and the clinical failure, sometimes with bacteremia, the hospital stay, and the time delay between the first diagnosis and the first dose of antibiotics is not only delay, but patients, for example, who reported penicillin allergy, 50% of the time had increased odds of having surgical site infections. So again, there are big implications from a statement. So what do we have to do? What is mandated to us? A detailed patient interview, I will show it to you 2 minutes. We have to have a medication history, and then we can have the decision-making process, direct challenge, graded challenge, descents, skin testing, and delabeling. When is it a good time to ask those questions? So I put here in the left side that when we see a patient in a routine perioperative, pre-transplantation, obstetric, when we see the patient in a setting where there is no urgency, that's the best time. When we have the patient in the emergency room, when the patient is inpatient and needs that, it's no longer a good time, although we can still proceed with doing an assessment. So every time a patient comes to see me and says, Dr. Castells, I want to see you because I have a mast cell disorder, I said, do you have a penicillin allergy? And the patient is like, wait a second, I thought the title was mastocytosis center. I said, do you have a penicillin allergy? So that's the first question. And then we'll proceed to mast cell disorders. But once we delabel a patient, which we will be able to do in more than 90 to 95% of the cases, then the patient is safe, and the choice of antibiotics in the near and long-term future is completely changed. So the labeling 101 is like the 2-minute drug allergy history. As allergists, I do a very prolonged, but you can just get the name. Patient says, I have a penicillin allergy. What actually did you take? If the patient remembers, maybe it was amoxicillin. So that's a different story. What was the indication? What was the timing? What was the date of the reaction? 40 years ago, 10 years ago, 5 years ago? Was there any blistering because of involvement? In this era, we have now the possibility of getting pictures. I tell my patients, when you have rash, just take a picture. Did the patient have similar agents tried? We have that multitude of patients that have a penicillin allergy. What was the last antibiotic you took for the bronchitis last year? Oh, amoxicillin. Okay, great. You don't have a penicillin allergy. So again, are there alternative options when we do that history? So we have now here in a very, very simplified way that you can rely on what is low risk. So those risk is patient who had a long time ago, over 20 years ago, this maculopapular rash, there's no hospitalization, there's no mucosal involvement, and does not have any impact in any organ. And for those low risk patients, we can actually decide when we want to do an oral challenge. We don't need penicillin skin testing. For intermediate risk patients, we might see that they had hives, they have some other, we will need some other type 1 reactions, we will need a penicillin skin testing. And after the penicillin skin testing, if negative, then we can actually give a challenge. And for the high-risk patients, we really need to go into, did the patient had potentially a scar, or did the patient had an anaphylactic reaction? That actually is a very different story. Even on high-risk patients, the patients who have had anaphylaxis can get back their penicillin, or their beta-lactam. Patients who had scars can never do that again. And you have here that we have what is called the pathways, which were spearheaded by Pitch Wigner and Kim Blumenthal from either the Brigham and the Mass General. And we have now categorized, in little tablets, what can be done at 2 a.m. in the morning when the patient is in front of you, has to be operated, they call us, or when the patient comes to the ER, they have pneumonia, and it looks like they need a beta-lactam. And so for the very low risk, the patients can actually use a cephalosporin. For the low risk, they might actually use a cephalosporin that has a different side chain than penicillin. And for the high risk patients, we actually might need desensitization or avoidance of that, and then choosing an alternative antibiotic. So again, cross-reactivity of penicillin with other beta-lactams, you have here, in this part here, and I'm sure that you all have that, is the cross-reactivity between, all the beta-lactams, cephalosporins, aminopenicillins, penicillin. And so sharing the side chain is critically important. The side chains might determine the Ig sensitivity, might determine the sensitivity that the patient may not be able to tolerate, a cephalosporin having had a penicillin allergy. But overall, the cross-reactivity is extremely low. And for example, for beta monobactams is almost zero. And for carbapenems, except for the aztreonam, is also very, very low. So we can proceed with those algorithms to be able to treat our patients. And for example, in a patient with a 25-year-old male with a rash 7-8 years ago, no mucosal involvement, no admission to the hospital, this patient was evaluated for perioperative penicillin allergy assessment, and he received a full dose cephalosporin. So there is a two pattern here and two ways here. One is, what can I do now? I can give a full cephalosporin, yes, and I'm doing that. There's no delay, and the patient can go to the OR now. What about the penicillin label? Can we actually remove that? So the patient came back later, had a skin testing and a challenge to amoxicillin, and the patient now has to have removed from their label the penicillin allergy. So again, it's not sufficient that we do an algorithm and we have a pathway and we're able to treat the patient now based on this low, intermediate, or high risk. We can also either refer the patient to the allergist or do it ourselves and saying, yes, I delabel the patient and now I can remove it. We have had patients who have had skin testing and a challenge for 20 years. Nobody had delabeled the patients, and they continue to have that in their medical records. So it's on our plate to delabel those patients fully. And here that is what I'm talking about. So the pathway use and the delabeling process. And when you have a patient that needs to be treated, it says here, many patients with a history of penicillin or cephalosporin can safely receive beta-lactams. So one is to use that pathway and then to actually delabel the patient once possible. And that is preventing the ordering of other alternative antibiotics. So we have here that the use of alternative antibiotics, and this is early work from Kim Blumenthal and our group, that you decrease by 50% the use of vanco, the use of aminoglycosides, the use of carbapenems, of quinolones, of linezolid. So again, not only a tremendous decrease in the cost of treating the patient, but in the hospital stay, in the potential complications and the delays in treatment. So this is a tremendous impact, and it is actually easy to delabel patients. So I want to dwell a little bit now in another piece that is important to us, which is there is complex allergies in the 21st century. Cancer patients survive longer and they are exposed to multiple chemotherapy treatments. We have patients with chronic inflammatory diseases and they have repeated exposures to new and fantastic monoclonal antibodies and biologicals. We also have cystic fibrosis patients who live longer, have lung transplants, and we have patients who have aspirin exacerbated respiratory disease who might do well with if we were able to reintroduce aspirin. We also have women, and this is not very common, but they can be infertile because they have a progesterone hypersensitivity. So how do we overcome that? So avoidance is probably not the way to go because of the life expectancy of patients who are on first-line therapies for cancer is greater than if we use second line. And the quality of life of patients who are in a good monoclonal antibody for their connective tissue disorder, for their RA, for the Crohn's disease is much better than if we don't use it. So substituting is sometimes not only expensive, but more complicated. And we also create, as mentioned before, more antibiotic resistance. So what is desensitization and how can you use it? We use it when we want to do first-line therapy, when we have medications that are less efficacious, and when we have had reactions that might be life-threatening. The desensitization concept is that inducing a state of temporary tolerization to a drug to which the patient has presented a hypersensitivity reaction. And we started the field with doing in desensitization type 1 with IgE, non-IgE, mast cell, basophil mediated. And we have now been progressing towards the field of type 4 reactions that are not scar reactions. So a classical presentation will be a young woman, relatively young woman who has ovarian cancer. She's given her first-line therapy, carboplatin, Taxol. She does well, comes back 2 years later, there's recurrence of the disease. She is now stage 4. Second exposure to carboplatin, she has flushing, generalized pruritus. This is her 9th exposure altogether. Shortness of breath, she has anaphylaxis to organ systems. She's given epinephrine. Her tryptase is elevated, 52. What do we do? 10 years ago, we would say, just use another drug, avoid it. And I'll show you at the end of my talk that not only 10 years ago, but like 4 years ago or 6 years ago, we continue to say that. Her oncologists have continued to say that. But what about evaluating the patient for potential desensitization? So the patient was evaluated, had positive skin tests, was given desensitization, and the patient actually entered another round of chemotherapy, was able to complete that, was given 2 to 3 more years of life. Patient here also rituximab reaction. It's a gentleman who has a mantle cell lymphoma, marginal cell lymphoma on rituximab, and he's continued on that, and he has done well. And after 8 exposures, now he has sweating, flushing, a little bit of more atypical symptoms, not so much the typical IgE type 1 mast cell mediated symptoms. He has a little bit of chills, different. So what do? We look at that expression, and we'll look also at what would be the endotype of that reaction. We drew what we call an IL-6, and we find that the patient has that. So the patient has positive skin testing when we evaluate him, and we have what we call a grade 2 reaction involving 2 organ systems, and we proceed to desensitize the patient. We start with a 3-bag 12-step, which is a classical way, and then we reduce the bags as we see that he has more a cytokine release reaction. So when we look at the hypersensitivity to monoclonal checkpoint inhibitors, immune modulators, we see that the more they have a murine pieces, the more allergenic they are, and the fully human or humanized, they are less allergenic, but still can induce reactions. And what we can see here, again, is the infusion reactions. Those infusion reactions are mediated by cytokines. Typically, pre-medication will help, no need for desensitization. The patient presents more at type 1, IgE or non-IgE with tryptase elevation, with histamine. Then we desensitize the patients, and we also do that for mixed reactions, for cytokine release, and for type 4 reactions, like I was mentioning, where there's maculopapular rashes that are benign with no mucosal involvement. And who are we desensitizing? Patients who present symptoms that are cutaneous, that are cardiovascular, that are respiratory. We have a symptom that is new, which is pain, muscular symptoms, and that we still don't understand what would be the mediators for that. Our evaluation is that the patients can have what we call type 1, type 4. We have biomarkers, and I'll talk to you a little bit more about tryptase and IL-6 and others. We can do skin testing, and we can decide on desensitization or providing the medication with pre-medication. We have here clearly that patients can have elevations, for example, when exposed to rituximab, to tryptase, normal range, quote unquote, 11.4. Patient had tremendous elevation of tryptase. Patients also can have elevations of IL-6. So we have now defined IL-6 as a biomarker of hypersensitivity reactions, which can be cytokine release, but also can be mixed, can be associated to elevations in tryptase. And what I can tell you is that we have a new kid on the block. Patients in the general population, 4 to 6% of our patients are going to have what we call now hereditary alpha tryptosemia, for short HAT, and is the most common cause of elevated baseline tryptase. And in those patients who have severe anaphylaxis, we have to do an acute but also baseline tryptase. And if above 7.5, we have to genotype those patients. They do have the chromosome 16 TPSAB 1 and 2 gene duplication or triplication of tryptase genes, and that makes the patient susceptible for more severe anaphylactic reactions. So we have had patients who react to one medication, to another, to foods, to what we think might be idiopathic. Those patients may have HAT, and we have to identify those patients. The biomarkers that we have for our patients are skin testing. We can do skin testing to most of the drugs, beta-lactams, chemotherapy, monoclonals. We also have defined specific IgE here. And why is specific IgE important? Because we are able to do cross-reactivity. With specific IgE, we were able to determine with Joanna Callado that the patients who react to oxaliplatin also have IgE-specific antibodies to cisplatin and carboplatin, so that they were not going to be treated just changing from oxaliplatin to other platins. There is a potential for a tremendous cross-reactivity. Basophil activation test, as I showed you here, we have a case of a patient who reacted to pertuzumab, and he had positive expression of CD203 activation marker in basophils. And so that patient was identified by basophil activation test. And we have a new test that we have defined, which is an in vitro test where we coat nanoparticles with the medication, either a platin or some other monoclonal antibodies, and we actually expose to mast cells in vitro, lines of mast cells, and we are able to see if they degranulate and they release mediators, and that would take precedent for skin testing or even specific IgE. And this is in the works, and we have a couple of years ago, we started to do that. Also, for your knowledge, there are patients who react to the medication at the first exposure. And how could that be? Because we just said that the patients need to be sensitized. Where, for example, patients reacting to taxanes, they react to Taxus baccata, which is from the bark of a tree. And that also we have seen is more frequent in people who have seasonal allergies, and they are likely sensitized to common determinants of other pollen. And those patients have tremendous amount of pain when they have that reaction. So their taxanes also are insoluble molecules that require chromophore and other solvents, polysorbate. So there's a potential for the patients to react to multiple medications based on reacting to their excipients, not only to the medication. We have here a good friend of mine who unfortunately died in 2016, and he was one of the most prominent primatologists in my hometown in Barcelona, Spain, and he did work in the field to provide evidence of that changing the habitat of the human change of animal habitat pushed animals out of those and decimated them. And he, by working in the field, he was had a tick bites all the time. And he created antibodies against the alpha-gal, galactose, alpha-1, 2, 3 galactose. And when he developed his throat cancer, he was treated with cetuximab and presented an anaphylactic reaction to cetuximab, which carries the same glycosylated epitope here that you can see, and he had to be desensitized to cetuximab. So previous exposure to something that was carried by the cetuximab made him already sensitized. The desensitization concept, again, high-risk procedure, critically patients, no alternative medication is temporary, so we have to re-desensitize patients. It's antigen-specific, and we provide repetitive suboptimal doses of the medication. Once completed, for example, if we do desensitize somebody to aspirin for cardiac reasons, we can maintain that desensitization by giving aspirin every day. The concept was born when I came to Boston with Frank Gossett and Howard Katz and where I understood and we published the first inhibitor of receptors on mast cells. And here mast cells have a molecule that's called gp49b1, and the T cells have alpha V beta 3, and they get together. And by doing that, mast cells are totally inhibited of the release of mast cell mediators. And I developed in vitro what we call now the model for desensitization through Ig mechanisms, but also works for other mechanisms, which is that here we have mast cells that are activated with an antigen, DNP, and then desensitized by, instead of giving individual doses, they are cumulative doses, one on top of each other, which is what we do with desensitization. And that blocks, this is a cell where calcium entry occurs with activation. And when we desensitize, we block calcium entry. And that is antigen specific because when we use another antigen that has not been desensitized, we have calcium entry. And the mechanism is that around the cells, there is no internalization of antigen, and tubulin and actin are not polymerizing, so the movements are blocked. So this model we have used now for the principles of desensitization, so that now we understand the threshold of anaphylaxis is here, and with desensitization we go below that threshold, taking advantage of inhibitory mechanisms in mast cells, and that we block a very powerful mechanism. Patients have positive skin tests before desensitization, they have negative skin tests after desensitization, so we actually block the internalization, the release of mediators, and we actually have an equilibrium of antigen outside the mast cell. And the candidates for desensitization are, what we said, IgE, where antibiotics, statins, non-IgE, taxanes, monoclonals, and then for type 4, all the others. We do risk stratification for the patients when they have to be desensitized, and we use pre-medications, but not steroids. So steroids is something that I want to mention that would actually have a full sense that the patient can be safe during re-exposure, and they actually do not prevent anaphylaxis. And we use aspirin to block prostaglandins and Singulair to block leukotrienes. And we have a universal protocol, and thousands of patients have been desensitized across the world with this protocol. And we are now looking at the potential roles of the anti-IgE and anti-IL-6 for patients who have difficult desensitizations. And patients desensitized, they can return to standard infusion. So we don't keep patients. We have algorithms now that after a few desensitizations, there is a vaccination type effect, and we are back. We desensitize to things such as progesterone for women who have infertility, who have presented anaphylaxis that is cyclical, and we have a very successful oral, intravaginal, and intramuscular protocols for progesterone desensitizations. We have also desensitized to, as I was mentioning, checkpoint inhibitors, we also have been successful at doing desensitizations to local monoclonal antibodies that are released or that are injected locally, and we have produced desensitization to those. we have understood, and this is one of the latest publications during the pandemic, that oxaliplatin-induced reactions, like other platins, we have a type 1 reactivity before the desensitization, and some patients present initially also by cytokine release or mixed reactions. And what is totally blocked during desensitization is the type 1 reactions. And during desensitization, we might still have a little bit of the cytokine release or mixed reactions. This actually works for any age. We have helped desensitize patients across the world. This is an infant in Mexico who, 1 year old, who had optic nerve glioma, and we actually she had a very severe anaphylactic event with carboplatin, a very positive carboplatin testing, and we desensitized her. She's doing well now. We have desensitized kids also. This is a kid in Peru with asparaginase. And the safety of desensitization is fantastic. The patients have either no reaction or very mild reactions in green, and only up to 6% of the patients have reactions that need stopping the desensitization and producing some interventions. But we have done, and we continue to do, about 900 to 1,000 desensitizations per year in the Dana-Farber Cancer Institute, where I have the Center for Desensitizations, and about 1 epinephrine per year, some years no epinephrine. So the safety is a testimony of the protocol. The costs are actually not increased when we desensitize patients, because we concentrate care. When they come, they are hydrated, they receive their potassium, they receive other things, and then they are desensitized. And most strikingly, the life expectancy of the patients who are desensitized is similar or better, and this was not statistically significant in patients with have recurrent stage 4 ovarian cancer, but with the sense that giving first-line therapy and potentially have a Th2 phenotype was actually helping those patients. And I just want to finish by a real quick think about this, what happened. I was telling you when desensitizations were actually offered around the world, and this happened to me, and I call it the beauty and the interconnection of the web, because this person didn't know me and calls me Mrs. Castells, and my mom, she's 57, she has cervical cancer, which is very, very efficient. And then she develops anaphylaxis at 8th exposure, and she's like, you're far away, you're busy, you're not familiar with my mom, can you help? And we actually, this is a work of a team. We convinced pharmacists, nursing, the oncologists, and we brought an allergist all virtually to this patient's mother, and she was successfully desensitized. You see here, October to February, it took a while to put this together. She was desensitized, and we says the last MRI shows that the tumor responded remarkably well to the treatment. So again, this actually puts together everything that I said to you, which is that it's typical to present it that way. More patients are going to need desensitization. We can provide those skills, and patients actually respond remarkably to that. We have also created an encyclopedia of non-drug hypersensitivity reactions with my colleague Anna Dune from Boston Children's Hospital and Alina Banerjee from Mass General Hospital. It's all available to you. It's open source from the JACI in practice, and we did that during the pandemic, and we offer general recommendations for what to do, how to recognize the reactions, as we said, how to grade them, what can be done about them, and what would you like your patient to have, either never be exposed, desensitized, or approximate delabeling. And we also offer all the specific drug recommendations, and I strongly encourage you to look at that. And so I would finalize saying that I want to thank also Steve Wasserman. He also encouraged me to go through this path. Drug hypersensitivity was something that nobody really wanted to do. It was thought to be time consuming, low yield, and at the end of the day, not much could be done. As I've shown you, not only by delabeling, but by understanding what happens to our patients with a drug hypersensitivity reaction, we can make a dramatic difference in their outcomes, in their life expectancy, in the quality of their life, and this is all that matters. And my job could never have been possible without, all here. We have all the nursing, all the pharmacists, all the fellows who are here, and all the faculty members that have helped me, and my mentor, Frank Austin, and all the people who have embraced the new generations. What I love about still being, very active at this is when we get every year, we get the new fellows in allergy, and the first, few weeks they're looking at these sensations like, ooh, you have a patient who actually had a cardiac arrest. We're going to put the patient back on the medication. And then the next 2 weeks, when we do that and the patient is fine and we're now able to provide first-line therapy, the patient, the fellows and you guys says, well, this is so cool. I want to do more of this. I want to write about it. So this is how, we have over almost 200 publications on this if you Google us. And we have a center. We are always there to help you. So any question, we have a forum that's open, an open mic for everybody and anybody, not only for allergists. If you have a difficult patient, just email us and we'll provide you a time, a slot, and we'll be able to help you. Having said that, I thank you. I hope you learned something today, and I'm delighted and wish I could have been there to be seeing all of you in person, and particularly Dr. Wasserman.
Great, wonderful. Thank you so much, Dr. Castells. Really appreciate a lot of insight. And even though I'm supposedly subspecialty trained in allergy immunology, I learned a lot, and you gave me a wonderful update as well, and some of the reactions. We're waiting for some questions in the Q&A, but maybe I can start. I always struggle with the cytokine release reactions, and you mentioned at times you desensitize and not. Is there any sort of broad-based guidance? Obviously it's case by case and drug specific, but broad-based guidance on when to desensitize these patients or to consider desensitization if the drug is necessary. And then also the second part of the question is, do you have any insight into the mechanisms when desensitization works regarding the pure cytokine release reactions?
No, those are very important questions. The first thing is that I don't want to desensitize things that can be substituted. So that's my first motto. So if they have a similar medication, I would go for it. A checkpoint inhibitors, they can choose another CTLA-4, another PD-1 or PD-1L. So I would really have a conversation with the referring physician. On the other hand, in those patients who have only no choice, or this is the actual best choice, we have defined what we call the phenotype of those patients, the fever, the chills, potentially chest pain or back pain. Some of them do a little bit of hypotension. In those patients, if we have the luxury to have an IL-6, for example, and it's elevated, those patients are very successfully desensitized. And the protocol for desensitization is changing from the 3 bags to 1 bag. And we have a whole recipe of IV fluids, COX-1 inhibitors. And so again, this is very personalized to the patient. Patients may also get a little bit of steroids, and not an excessive, but for those pure cytokine release reactions. The most interesting thing is also that we have like a lot of mixed reactions, which is incredible. I never thought that would be possible to have a mast cell activation and then a cytokine. And that tags along to your question is, what is the mechanism of that? So we know that mast cells have some IL-6. So is it possible that we have, a differential release because, the drug affects differently? The mast cell receptor is not through an IgE receptor, it's through another mechanism. So we're working on that. It's also possible that, for example, there is tumor release of that during the drug exposure. And then there's also the potential for monocytes and macrophages who are, great producers of IL-1 beta, TNF-alpha, and IL-6. We do think that not only IL-6 is elevated, we have measured TNF-alpha and IL-1 beta. They're also elevated in a lot of those patients, but we resort to just do IL-6 because it's easy, it's cheap, and it can help us. So again, one-on-one basis, we are taking more the lead on doing that more consistently. So we'll be able to publish, a kind of full cohort and give the recipe, but it's not as easy as type 1. I agree.
Great, wonderful. And I also would like to thank you for showing the level of importance of delabeling patients. Thank you for spending that time. That's obviously near and dear to our hearts and our field. But also the importance of setting up drug allergy centers and what we can do for these patients, and also their providers, their care teams. So thank you very much. And on behalf of Dr. Wasserman, who is somewhere in the crowd listening to you, We appreciate your time, and we will send you a link with an interactive session with our fellows. Thank you so much, Dr. Castells.
Thank you.
Thank you, Castells.
Yes.
You can log off if you like.
Okay, and then I have another link to go, right?
Yes.
All right, very good. Thank you so much. Thanks.
Thank you.
Bye-bye.
Bye.